you need to get these patients dialysis. Sometimes they're clotted, they've missed dialysis for 3 or 4 days.
The presence of thrombus is a real wild card. If we do a thrombectomy and we angioplasty a lesion that is suspect in terms of its responsiveness, and we're not sure how it's going to behave, we will often bring that patient back in 30 days to examine the graft.
The challenge with treating a thrombosed access at the graft vein anastomosis stenosis with PTA alone is the risk for recurrent short-term thrombosis.
The challenge is if it doesn't respond with angioplasty and repeat angioplasty, what do we do next? Do we need to have surgical revision, or do we have other endovascular strategies?
It's frustrating for us. It can be dangerous for the patient who's missed a lot of treatment days, and it can be challenging logistically for the patient to come back and get the procedure done adequately.
If the patients come back 2 or 3 times, angioplasty didn't work and they keep on clotting, there's something wrong. You have to fix the problem. And angioplasty alone will not fix the problem.
And in those cases, what we try to do is work together with the interventionalist and surgeon to take a look at the type of lesion, what are the factors associated with it, and then typically we would go to the next step, which would be a stent graft.
I really have much more faith in the ability of a stent graft to keep that lesion open than I would with angioplasty alone. By placing a stent graft along that site of graft vein anastomosis stenosis, we kind of change the natural history of that graft. We allow a more durable site at the venous anastomosis stenosis. We exclude the neoendomal hyperplasia from the lumen, and we allow for passage of blood through that area that potentially can continue flowing without recurrent thrombosis.
Yeah, so it really depends on how confident one is that the stenosis was the cause of thrombosis, which it often is, or even usually is. And if one can be reasonably certain that there was significant stenosis that resulted in thrombosis, then it makes a lot of clinical sense to treat that with a Vibon device and follow the level 1 data that says that provides a better outcome than angioplasty alone.
70% of my patients, if they have a recurrent problem at the venous anastomosis, I would put in a Vibon device in that area.